Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you, and we aim to take around 15 to 20 minutes. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Welcome to Glenohumeral Gurus. In this podcast, I talk with Dr Angela Cadogan, a specialist physiotherapist here in Christchurch, New Zealand. We discuss all things acromioclavicular joint, diagnosis of acromioclavicular joint, and how Angela structures her treatments. Enjoy. Hey, so it's my great pleasure to welcome Dr Angela Cadogan to our Glenohumeral Gurus podcast. And thanks for taking the time to join us. I'm really excited to talk to you today about AC joints, and I'm glad things have kind of lined up for you. So, and for our schedules, that was really a bit impromptu, but really nice to connect with you.
Having me, Margie. I'm looking forward to it.
Yeah, it's gonna be fun, I think. So these podcasts are designed, they're just short, 15 to 20 minutes for clinicians to get some clinical takeaways and to learn from what people are doing around the world in the space of shoulders. Why do you think we should talk about AC joints? What's new in AC joints? What have you got for me?
Right. Well, I think probably, I guess my background as a physio and ending up as a shoulder physio and a specialist shoulder physio, which is my subspecialty area. So in my clinical practice, I see obviously a lot of second opinions, as many physio specialists do in New Zealand. And it was interesting that I was looking back at some of my data on some of the patients that I've seen over the last few years. And normally when we're talking about shoulders, it's really often that we're talking about frozen shoulders and rotator cuff and shoulder instability. And intuitively, I would have thought that those would have come out on top of the most common things that I see in my practice. But in actual fact, it was the AC joint that came out on top. So 17% of the patients that I see in my clinic, so that's almost 1 in 5, have an AC joint problem. And if I look back, some of my PhD research that I did back in 2012, which was more in the primary care or primary contact setting, it was still 14%. So, and that was injection confirmed AC joint pain. So, in primary care, people walking in the door of a physiotherapy clinic, there's about 3 in 20 patients that are going to have an AC joint problem or a symptomatic AC joint problem. And in my specialist setting, so that's patients who have already had physio, they've often already seen doctors, they've seen surgeons, they've had imaging, and they end up with me because, no one else knows where to send them. And that's 17%, so almost 1 in 5 patients that I'm seeing. So they're very, very common. And when I talk to other physios about AC joints and sort of ask them, are you seeing them? And they sort of like, oh, no, not really. So I think I can take from that I think if you're not seeing them, they're definitely seeing you.
Yeah, the AC joints are seeing the physios, but the physios aren't recognizing that, eh?
Right. Yeah.
Yeah. Hey, so I kind of rushed into this because I know you so well, but there's probably, do you want to just share with everybody how you got to be talking to me about AC joints? I'm sorry, I kind of assume that everybody knows you as well as I do. So do you want to share with us just your physio journey and how you get to me talking to me about AC joints?
Yes, sure, Margie. Well, I mean, I started off life as many physios do, running around on the sideline of sports fields, and I actually ended up going down a sports physio pathway initially, and I got my master's degree in sports physio from Curtin University in Perth about 1 million years ago.
Yeah.
And so after my master's, I got a job with New Zealand Cricket, and I was working with as the physiotherapist for the national women's team, the White Ferns, and ended up also working a lot with the elite men's teams, the A programs, and sometimes a little bit with the Black Cats as well. I did that for about 10 years, and I got really interested in the throwing shoulder. And
Mm.
that was actually initially going to be the topic of my PhD, was the throwing shoulder, but it sort of
Okay.
morphed and took a different turn, and it ended up being a diagnostic accuracy study, a validity study, so looking at the accuracy of clinical and imaging tests for sources of shoulder pain. And then since then, I've really just been seeing shoulders in the clinic, and became registered as a specialist in about 2015, I think, so almost 10 years ago now, and that's all
Wow.
I see these days.
Yeah.
So that's
Yeah, cool. Well, yeah, thanks for the synopsis. It's very elegantly put, as always. And so now, if we come back to physios missing AC joints in the clinic, why do you think that is?
Well, that's a very interesting question. And I have heard the AC joint described as the great pretender. And that certainly resonates with what I see clinically. So I think misdiagnosis would be probably number one, and just not recognizing that the pain or the symptoms that the patient is describing are coming from the AC joint. And it's not only physios that are missing this. I think the patients I see have often been right through the whole medical system. They've seen GP, they've seen physio, they've seen often sports physicians, orthopedic specialists in many cases.
Mm.
And I think why it's called the great pretender, if you look at the two types of AC joints conditions, so you've got traumatic conditions, which are your instabilities and fractures particularly, and the atraumatic conditions. So that's the group that really does seem to be missed. I think the
Mm.
traumatic ones we're all pretty good at picking up. You know, if someone's fallen on the point of the shoulder and they've got pain in the superior shoulder, that's fairly straightforward. The atraumatic ones are not so straightforward. And I think the great pretender comes from the fact that the pain from atraumatic AC joint conditions refers quite distant from the AC joint. So a lot of
Mm.
patients will report pain, particularly over in the suprascapular fossa, so just around the top of the shoulder blade and in the upper traps region.
Mm.
Sometimes it'll radiate up into the neck, down into the axilla, so down into the medial arm. And they know this. They've actually done injection studies where they inject saline irritant into the AC joints of
Okay.
volunteers, and they've mapped out the pain patterns. And
Yeah.
they find that, yes, some people do feel it on the top of the shoulder, but in many cases, it will radiate quite distant to that. So I think that puts a
Mm.
lot of people off the scent of the AC joint. And the
Mm.
ones that I see in the clinic have often, because of that location of pain being up in that neck area, the suprascapular area, sometimes even the subclavicular area, the axilla, they've
Mm.
often had a lot of treatment around the neck. They've had massage, they've had stretching, they've had cervical spine treatment, and nothing's touched it. So I think the pain location is one that really throws us off the scent. The other one, though, I think, is imaging. And even on imaging, it's underreported. So I'm talking
Yeah.
about AC joint arthropathies here. So
Yes.
maybe the subtle osteolysis, which is resorption of that distal end of the clavicle, which you often see in people doing a lot of heavy or repetitive overhead activity. But the AC joint arthritis. And so often seeing radiology reports where maybe the physio's been treating them, has quite rightly identified they're not progressing, so they've gone ahead and done what they should and ordered the
Mm-hmm.
imaging. And the imaging report comes back with the AC joint reported as normal. I never listen to that. Always look at the imaging yourself, because so often when you look at the AC joint and you really, magnify it on your radiology viewer and play around a little
Mm.
bit with the brightness, often you will see signs of AC joint arthropathy. You'll see a bit of sclerosis. You'll see a bit of the dark patches in the subchondral bone, which is the bone cysts, which is a sign of arthropathy. And you ring the radiologist and say, well, the patient's presenting clinically with AC joint pain, but on the imaging report it said normal. They said, oh yeah, it actually is, like there's arthropathy on the imaging. So
Yeah.
very underreported on imaging.
So they're missing them as well, eh? I'm feeling a bit sorry for all these people with AC joint problems.
Yeah, it's interesting. Are they underreporting them, or are they just making an assumption that it's normal for age? And sometimes they'll even put that on the radiology report and say normal for age. But I also think that as a profession, I think we're starting to get really swayed by the over imaging message. And I think that's rightfully so in some cases, but I almost think that now we're almost writing a lot of imaging findings off that actually are symptomatic. And yes, there is a high prevalence of asymptomatic AC joint pathology on imaging. And if you look at MRI studies, it can be as high as 80 or 90% of people with no shoulder pain have AC joint abnormalities on imaging. We don't see that population. And I think when we're looking at imaging studies, we don't see asymptomatic populations. They come to us because they've got pain. So I'm more interested in what is the prevalence of imaging findings in the symptomatic population. And you'll find with the AC joint that is much higher. And in fact, there was one study that looked at people who had injection-confirmed AC joint pain. 100% of them had AC joint arthropathy on imaging. So I think we've got to acknowledge that, yes, some findings can be asymptomatic, but I think we've almost got to be careful that we don't start missing things because of that, and we really have to correlate things clinically.
Yeah, that's great advice. There are some other things, other conditions that might also affect AC joints. Do you have any thoughts on what you think that might be? How they involved? I guess especially in these arthropathy cases, eh?
Yeah, that's right. So I think if you look at the most common causes of non-traumatic or atraumatic AC joint pain, so you've got the distal clavicle osteolysis that I mentioned before. So that is often seen in weight trainers or people that do heavy or repetitive overhead occupations. And it is a resorption of the distal end of the clavicle. So it's sort of a disruption of that bony metabolism, a bit like a stress reaction in a way. So that's one cause of AC joint pain from no specific trauma or no high force trauma. AC joint arthropathy, definitely. So that's an arthritic or a degenerative condition. Probably not so much exactly the AC joint itself, but around that area is the os acromiale. So that's an unfused acromial ossification center. And it's quite late to close. It's sort of between 20 to 25 years of age when that one will close. So if you're seeing anyone under the age of about 20 or 25 who's reporting sort of pain around that top of their shoulder, and sometimes because it's an unfused ossification center, it can be mobile. So sometimes those patients also report a bit of clicking when they're using their deltoid, particularly. So deltoid attaching to that acromion. So doing any kind of abduction or overhead activity. So a painful clicking, and in anyone under the age of sort of 20, 25, I'd be definitely getting an x-ray. And look at that yourself as well, because a few of those have been missed too. It happens in about 6% of people where it doesn't fuse. And if they're using their deltoid a lot, or sometimes if they fall on it as well, that can actually just make it become symptomatic. And probably the other one, the most common one would be what I'd probably call just a functional AC joint problem. So the actual joint itself is fine, structurally intact, no real pathology, but the overall mechanics of the whole area, perhaps they've got a real scapular dyskinetic pattern where the scapula is sitting really low, or the muscle patterning, they're using some of their big global dominant power muscles to sort of move and try and stabilize the scapula. And all of that creates torsion and stress at that AC joint. So that's probably another one that I'd see, which is kind of a secondary to biomechanics or scapular dyskinesis, if you like.
And do you see any relationship? Like often I think about at the other end of the clavicle, at the sternoclavicular joint. Do you have any little gems for us there. What are you? What are your gems?
I could talk all day about
Ah,
sternocleidomastoid.
yeah,
Maybe that could be another podcast. But
yeah.
effectively,
Let's do that.
well, we should. But in a nutshell, they do actually present very similar to the AC joint in the fact that even the pain location can be similar in that supraclavicular region. The
Yeah.
sternoclavicular joints often pain along the clavicle, even the medial clavicle, subclavicular region. Very few of them actually point to their sternoclavicular joint and say, that's where my pain is. It's often much more diffuse than that. And if you
Yeah.
look at that clavicle as being I've seen made the analogy of an industrial crane with the
Yes.
clavicle as the boom. And if you look at the boom structure, it's got to be attached to something, and that's the attachment at the sternoclavicular joint. And then it's also got its job to do at the other end of the clavicle, which if you're
Yeah.
looking at the boom analogy, it's got to move the boom up and down using its upper trapezius. It's got to stabilize and hold the whole weight of the arm while we've got load in our hands. And it's got to move that boom forwards and backwards, and that's how we align our glenoid and our humeral head. So it's got a lot of work to do, and if you have a problem at one end of the boom, it's going to affect the other end as well. So I think that sternoclavicular joint is also really important to look
Yeah,
at
cool.
in
Hey, well,
anyone.
let's make another time to talk sternoclavicular joints. I'd really enjoy that.
Do that.
Enjoy that. In terms of diagnosing AC joints, what are your key go-tos? I'm interested if they're the same as mine. What have you?
Right. Well, yeah. My key go-tos are making sure it's nothing else first. So
Okay.
I'm excluding a frozen shoulder. I'm excluding any significant pain or weakness with resisted rotator cuff tests.
Yeah.
And I'm excluding cervical spine, obviously, as well in the first instance. Now, if you've excluded all three of those things, and we're assuming it's not an unstable shoulder either, there's not a lot else that it can be in the shoulder, and you're starting to really narrow down your probabilities of what might be the problem down to the AC joint. And once I've excluded all those other things, what I tend to find, we know from the evidence of accuracy around our special tests that they're not that special, that the positive likelihood ratios are really actually pretty poor. Even when you combine the tests, they're only down around sort of 1.7 or 2 as a positive likelihood ratio, when we actually really want one that's 5 and above to be really that clinically useful. So rather than the special tests, which I might bolt on at the end if I'm still really searching, but I'm looking at end range pain with our active movements and passive movements, particularly in elevation, adduction, and hand behind back are the main three, and palpation around that AC joint as well. But being careful to compare that with the other side, because they can be tender anyway. So excluding other things, end range pain, palpation pain. And if I'm really hunting, I'll use my special tests for the AC joint, but they're very much kind of second tier tests in my book.
That you would, and the tests do you want to just elaborate on those tests that you would bolt on then, just to confirm?
Definitely. So we've got the scarf test, we've got the AC resisted extension test, which is the arm held kind of in the Hawkins-Kennedy position almost, or just 90 degrees forward flexion with the elbow bent and then pushing back against resistance into more of an extended position. And the active compression test is also one that I would use. There are others. There's a Paxinos test, which is a sort of a compression or a shear test of the AC joint. And there's a variety of other ones as well, but those are the main three that I would use really, are the scarf, cross-body adduction, active compression test, and the AC resisted extension.
Yeah. So sometimes I find it really difficult, especially in that, sort of that grumbly, that AC joint that's not obviously an acute trauma, is to tell the difference between AC joints and posterior instability, because all those things are all they're all putting stress on the posterior aspect of your shoulder. Have you got any gems for me there? What have you?
Yeah, it's I think that's where my symptom modification would come in, particularly as regards to the posterior instability. So I think it's easier to figure out that it's not a posterior instability than figure out that it is an AC joint.
Yeah.
So I would just be supporting the posterior humeral head and recruiting the external rotators through range and see if that changes their symptoms. And if it does, probably more the posterior instabilities. For the AC joint, often you'll see a very sort of complex clinical presentation. Some patients with high levels of quite widespread pain, it can be really difficult to differentiate even from a rotator cuff sometimes.
Yeah.
And one thing that I do use occasionally is just the scapular movements. So we're talking scapular shrug or elevation, protraction and retraction, and scapular depression. So the benefit of those tests is the arm is by the side, so you're not actually moving the humeral joint. And if you're reproducing a person's pain with scapular elevation or shrugging, depression, protraction, retraction, more so than with glenohumeral movements, then there's a good chance that it could be the AC joint.
More likely, yeah. And so what kind of rehab advice have you got for people? What should physios be doing once they now are paying attention and see the AC joint? What should they do?
Yeah, well, that's good. And it depends a bit on whether it's acute and traumatic or atraumatic. But I think the acute ones are fairly straightforward, with a period of relative rest for comfort, range of motion, and then sort of getting back into strengthening and rehab. The atraumatic conditions, though, I think they're the difficult one. And that's where the diagnosis becomes really important, because that leads directly then to prognosis. And that is what informs our patient expectations and beliefs about not only their end point for outcome, but also how long it's going to take to get there. So for somebody with, say, a younger person with that clavicle osteolysis, we know that if they keep bench pressing twice their body weight 5 times a week, that is not going to settle down. So they have to understand why it is that you're pulling them out of bench press or certain exercises in order for it to settle, and that it is going to take months. When you're talking about bone remineralizing, that's months for that to settle down. Same thing, same principles really with the AC joint arthropathy. It's a degenerative condition. We cannot cure that, and that's not a failure of physiotherapy. That is the nature of the condition. But there are things that we can do to optimize function around that AC joint. We can advise on activity. We can get the patient to understand what is most likely to provoke AC joint pain, give them some alternatives in the gym or other exercises that don't stress it quite so much. Attention to range of motion, so particularly those posterior shoulder structures, and the range of internal rotation is one thing that I find is often missed. And if they're tight with internal rotation, they'll be tilting their scapula,
dragging themselves around.
Yeah, and it will just annoy the AC joint. And scapular rehab, I think, if they've got any scapular dyskinetic features at all, obviously that is also going to put a lot of stress through that AC joint. So scapular rehab is crucial. And the thing that I'm probably seeing much more in my specialist setting, which might just be the nature of the patients that make it through that far, is upper trapezius function. And if you look at upper trapezius, often we've spent a lot of our time trying to turn it off, and we say it's overactive and it's working too hard, and we're massaging it and stretching it and dry needling it and trying to turn it off. Well, if you see a patient, the sort of presentation I mean is a patient that comes in where that scapula is sitting really low compared to the other side. They ask them to shrug. They very often can't actually fully upwardly rotate or shrug that scapula. The upper trapezius needs to be able to work. It is the one muscle that initiates that upward rotation of the scapula. And if someone's having trouble getting their arm above their head, they're going to need a good functioning upper trapezius to be able to do that. So looking at upper traps and is it functioning? Do a good old Kendall and Kendall muscle test on upper traps to see, is it strong enough? And can they actively move that scapula into elevation in the first place? So that would be another rehab
Yeah,
tip.
cool. We should get another podcast about that. I'd love to talk to you more about that, because that hasn't been my approach, and I wonder more about, posteriorly tilting and upwardly rotating rather than just elevating. But we should talk about that another time. I think that would be really interesting.
Be
It's
very happy
I
to
think
do
I
that.
guess when you think about the attachments of upper trap, how it blends in across that, like you say, it definitely then probably offers some support for that AC joint as well.
Absolutely, yeah. Its anatomic attachments really give it stability, but they also rotate that clavicle posteriorly, and they upwardly rotate the acromion. So, and that's everything that you need to initiate elevation of the arm. And if it's not working, then something else is going to have to compensate for that, or not.
Yeah. Let's schedule another time to talk about that.
I would
Finally,
love
is there
to.
anything else you wanted to talk about? I know you're really busy, aren't you, with your clinical practice and with Physio Academy and your Shoulder Academy? And do you want to just share that with people as well? Give them a bit of an understanding about the other work that you do outside of being this amazing clinician?
Thanks, Margie. You're very kind. So I do run Physio Academy, which is really was born out of just having the need to find somewhere to put some online courses back in 2016. So myself and Mark Laslett, who also had online courses at the time, just got together and built a platform, which eventually became Physio Academy. And we mainly have shoulder, lumbar spine, and concussion courses on that these days. We've got some other things on there as well, but if anyone's interested in looking at that, it's physioacademy.courses. As part of that, I do run the Shoulder Academy, which is really just kind of a support network really for physios, where it's an online community, but we do also run live Q&A sessions. We actually have the AC joint one coming up, I think, in about 8 weeks' time. So yeah, we have a theme. We do 5 of those a year. AC joint is coming up. There's also courses available on there. There's a discussion forum. If people have got cases they want to discuss, they can kind of write in and ask for advice about cases. So that is shoulderacademy.co.nz if anyone's interested in having a look at that. So yeah.
And the mentoring stuff, we haven't really talked about that. I just wanted to...
No, we haven't. That's right. So yeah, a couple of years ago, Physio Academy partnered up with Margaret Potter, who actually is a New Zealand trained physiotherapist, but she's now based in Australia, and she's doing a lot of training of trainers and mentors and clinical supervisors. And we actually ran a mentoring study, which was for new graduate physiotherapists, and we had 33 fabulous new graduates and matched them up with some mentors, and we published the results of that in the New Zealand Physiotherapy Journal late last year. Now, since then, we have partnered with Margaret, who offers a mentoring on the run course as well. So she runs that herself through her Australian platform, and she's actually coming to the Physiotherapy New Zealand conference in September this year, and her and I are running a mentoring workshop as part of that conference. So if anyone's interested in mentoring, then come along to the conference and you can hear more about that.
Cool. Hey, Angela, thanks so much for your time this afternoon. It's been an absolute delight, as always. And I'll be in touch, and we can schedule a further SC joint discussion in due course. So, yeah.
I would love to do that, Margie. Yep.
Yeah.
Anytime.
Thanks very much.
Thanks, Margie.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media via Facebook, Instagram, LinkedIn, or Twitter. I'm happy to get your feedback about the content, and if we can improve that in any way, or talk to researchers or clinicians who you would like, then I'm happy to do so. Don't forget, you can follow me on my social media for some more up-to-date content. You can also access me for patient-specific help. If you'd like to do that, then I also offer that service via telehealth worldwide. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. The instability course was designed to accompany the clinical concepts paper that we published in the Journal of Athletic Training. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.